Assalamu alaikum. In the assessment of acute sore throat cases, some fundamental questions need to be answered. In this presentation, we shall review the evidence to answer these four fundamental questions. Acute sore throat condition is self-limiting and usually resolves on its own or with the help of antibiotics and other medications within few days. The four fundamental questions start with this. Is this a bacterial or a viral infection? And who needs the antibiotics, knowing that only few of the patients would require treatment with antibiotics if they have a bacterial infection severe enough? These two first questions should be answered mostly on clinical grounds using the scoring systems of either the Centor score, the McIsaac, or the FeverPAIN scores, and they usually answer the questions effectively. But what if there is no improvement, or if things are getting worse? Then we need to answer the other two fundamental questions. Could it be something else? Is there an alternative diagnosis? And whether there is a possible complication, whether local or systemic. Again, the questions would be mostly answered on clinical grounds, but for the last two questions, some investigations may be needed. When would things go wrong? When the symptoms are very severe, or when they persist despite adequate management, or when there is no improvement after 10 to 14 days, or when the symptoms are getting worse. Then we should consider some other alternatives or diagnoses, including peritonsillar abscess, infectious mononucleosis, scarlet fever, Lemierre syndrome, Vincent angina, or a systemic complication like a suspicion of acute rheumatic fever. The first fundamental question in the management of sore throats, who needs the antibiotics, was addressed by several national guidelines, including the SIGN guidelines 2010 onwards. It's based on distinguishing a viral from a bacterial etiology as the main reason for the infection and trying to assess the probability of the bacterial infection being caused by group A beta hemolytic strep by risk stratifying. The most common bacterial pathogen is, of course, the group A beta hemolytic strep, for which antibiotic treatment may be considered. There isn't a single symptom or sign that can establish the distinguishing criteria for the differentiation, but a combination of different signs and symptoms, different factors, have been useful in several clinical prediction schemes, including the Centor clinical prediction score and others. And the guidelines starting from 2010 onwards suggest that the use of such schemes can be useful in answering this question without the need for any investigations. Now let's consider this example. Say if you have 100 consecutive cases of acute sore throat. You know that roughly 25% of those 100 patients would have a group A beta hemolytic strep, and those are the patients that would require or benefit from the antibiotics. The real question is, how can you identify those 25% out of the whole lot to avoid giving the 75% an unnecessary antibiotics and to treat the 25% who need the antibiotics? There will be some true negative cases and some true positive cases, but there will also be some false negative and some false positive cases. So there would always remain a certain degree of ambiguity in the risk stratification of those patients. Now, generally speaking, the clinical scoring systems are good at identifying the true negative cases if the scores are very low. If the scores are 0 or 1 or even 2, then it's very unlikely that those patients would have a group A beta hemolytic strep. These are the gray circles here, and they can avoid having an unnecessary treatment. The efficacy of the scoring systems is less in identifying the true positive, but it's even less in identifying the other group of patients with the yellow and red circles who are either false negative or false positive. A sensitivity test suggests that roughly using clinical scoring systems, one would miss 25 to 50% of patients who have a group A beta hemolytic strep as false negative. Those patients may have benefited from antibiotics, but the test had indicated, the scoring system had indicated that they are free. And the specificity test would say that 20 to 40% of the cases would be labeled as having a group A beta hemolytic strep with a negative throat swab or culture, that is to say a false positive. Those patients would have antibiotics unnecessary, in contrast to the red circles who would not have antibiotics when they actually need it. We'll go through 3 clinical scoring systems that are currently used for risk stratification of acute sore throat patients. The first is the Centor score, which was developed in the USA in an emergency department setting as early as 1981. It's limited to patients who are at least 15 years of age. The Centor score gives 1 point for each of the following 4 items. If there is tonsillar exudate, if there is tender anterior cervical lymph nodes, and a history of fever more than 38 degrees centigrade, and absence of cough. So the maximum possible score would be 4 if you get these 4 points together. The likelihood of having a group A beta hemolytic strep infection increases with the increasing Centor score. So if the Centor score is 0, that is to say you have not scored anything in the 4 items, the body temperature is less than 38, there is a cough, there is no cervical lymph nodes tenderness or swelling, and there is no tonsillar swelling or exudate, the score is 0, chances are less than 2.5% that there is a group A beta hemolytic strep. If you have only 1 positive item out of the 4, you score 1, the chances would increase to between 6 and 7%. 2 items, the chances would still be around 15%. 3 items, then the chances would be more than 30%, about a third of the cases would possibly have a group A, and all the 4 items, the chances are more than 50%. You are more likely than not that there is a group A beta hemolytic strep. The guidelines would advise that if the score is 3 or 4, then an antibiotic prescription should be considered. The Centor score can only be used for patients who are 15 years or more, and the age of the patient was not considered in the criteria of the Centor score. A modification of the Centor score by McIsaac and his colleagues had added the age of the patient to the criteria of the Centor score. So if the patient's age is between 3 and 14, you can add 1 point. If the patient age is more than 45, you subtract 1. And if the patient age is between 15 and 44, then there's a 0. You can add 0. This is taking into consideration that group A beta hemolytic strep is more prevalent in the group of patients between 5 and 15. That's why a +1 can be added to patients in this age group. The McIsaac score, the modified Centor score, is basically the 4 criteria of the Centor score: temperature above 38, no cough, cervical lymph nodes tender or swelling, and tonsillar exudate or swelling. These are the 4 items of the Centor score. To this you may add the age factor. If patients are below 15, then they would have 1 point. If the patient are more than 45 years of age, then you subtract 1 point, and between 15 and 44, you get a 0. And again, the likelihood of having a group A beta hemolytic strep increases with the increase in the score. So at a score of about 0, the chances is almost 1%. If there is at 1, if there is only 1 factor of this, the chance is about 10, and it increases gradually. The maximum score would give you a chance of about 50% that there is a group A beta hemolytic strep. The FeverPAIN scoring system incorporates 5-point scale with 1 point for each of the following. If there is fever, this is the fever part of the FeverPAIN scale. During the previous 24 hours before the consultation, then you get 1 point. The pain is a P for purulent on the tonsil, pus on the tonsil, and an A if the patient attend rapidly within 3 days from the onset of symptoms, if you attend consultations rapidly, and an I for an inflamed tonsils, severely inflamed tonsils, plus the pus on the tonsils, and an N for no cough or nasal congestion or drip. So this would give you the 5 points scale for the FeverPAIN criteria. Then 3 clinical decisions can be taken from there. If the score is 0 or 1, then no antibiotics are required. If the score is 2 or 3, then you can either give the patient a delayed prescription for antibiotics to use it only if symptoms get worse or does not improve in 3 days. Around 2/3 of people who have the delayed prescription will not use it. If the score is between 4 and 5, then the patient would require immediate prescription for antibiotics. This is a quick comparison between the 3 clinical scores. Starting with the Centor, these are the 4 criteria for the Centor. The number 1 criteria is that there should be no cough, and this is repeated by the other 2 scoring systems. The FeverPAIN would add no cough or rhinitis. The other factor is history of fever. This would be repeated also with the McIsaac. It will specify that the temperature should be more than 38 degrees, and the FeverPAIN would insist that this should be in the preceding 24 hours before the examination. So these are 2 of the 4 factors. The third is tonsillar exudate. This is the same in the McIsaac and the same with the FeverPAIN. Now, the anterior cervical lymph node swelling or tenderness is also mirrored in the McIsaac, but it's not included in the FeverPAIN. The FeverPAIN, on the other hand, has 2 other factors. One of them is quick or rapid presentation within 3 days of the onset of the symptoms, and the other is, in addition to tonsillar exudate, there will be a severely inflamed pharynx or tonsil. On the McIsaac, there will be 1 added factor, that of the age, where age before 15 years would add a point, and more than 45 years you would lose 1 point. Note that with very low scores, like a 0 or a 1, both the Centor and the McIsaac would have very low chance of having a group A beta hemolytic strep. With the FeverPAIN, the probability is higher. With a FeverPAIN score of 1, the probability is about 16%. This is almost double the probability for the other 2 scores. Note that the FeverPAIN is actually designed to risk stratify not only group A beta hemolytic strep, but beta hemolytic strep in general, including other groups like group C and group G. Now, the maximum possible score for the 3 of them would give a probability of between 56% or so and 63%. This would be the maximum. So there will always be a chance of missing maybe somewhere between 40 or 50% of the patients infected with group A beta hemolytic strep, even with the highest possible score of the 3 different scoring systems. Now, comparing the high scores of the Centor versus the high scores of the FeverPAIN in 100 consecutive cases of acute sore throat, would show that with the Centor scoring, it would identify the true negative cases, the gray ones here, in 73%. The FeverPAIN would identify 82% of the true negative cases. And the true positive, the Centor would identify 4, and the FeverPAIN would only identify 1 true positive. And then there would be false positive cases for about 11 cases in the Centor and only 2 cases in the FeverPAIN. And then the false negative cases will be 12 in the Centor and 15 in the FeverPAIN. So this is just a graphic comparison between the two scores. It would show that with the high scoring, FeverPAIN is better at identifying the true negative. The Centor scoring would be better at identifying the true positive cases. The diagnosis of a peritonsillar abscess is usually made on clinical grounds. It indicates separation in the peritonsillar space between the tonsil capsule and the superior constrictor muscle. On this MRI scan, you could see the tonsils here, the rounded structures with the art stick in it. The superior constrictor muscle is just lateral to this. In between, there is this small peritonsillar space. Anterior to the tonsil is the palatoglossus muscle there, and posterior is the palatopharyngeus muscle. Just lateral to the superior constrictor muscle is the paraglottic space with the black art stick in it, and a little bit more lateral is the medial pterygoid muscle. Inflammation in the peritonsillar space can cause irritation of muscles of mastication. The inflamed area in the peritonsillar space with collection of pus would displace the tonsils medially and also displace the uvula. A peritonsillar abscess is more common in the age group between 20 and less than 40 years and affect males more. The predisposing factors including smoking and poor dental hygiene and immunodeficiency. Data from England over the last 2 decades had showed a substantial increase in the incidence of peritonsillar abscess. This has coincided with the implantation of policies to reduce tonsillectomy operations, and it was noted that few years later the incidence of peritonsillar abscesses has increased along with other neck space infections. 2 different types of microorganisms can cause a peritonsillar abscess with 2 different subtypes. The type 1 is a pure culture of a single organism, mostly the group A beta hemolytic streptococci. The type 2 have a heavy polymicrobial growth with different strains of bacteria, including bacteroids, the anaerobes, and streptococci, the aerobes. Clinically, the type 2 appears to be more severe, probably because of the synergistic action of the microbial interactions. The vast majority of peritonsillar abscesses would be diagnosed clinically. There would be unilateral throat pain and fever, trismus, and unilateral ear pain and headaches. There will also be difficulty in swallowing and painful swallowing, amounting to drooling of saliva. The voice would be muffled like a hot potato voice, and there would be ipsilateral gyrodagastric lymph nodes enlargement and tenderness. An acute tonsillitis would precede the development of quinsy only in 30% of the cases. In advanced and neglected cases, there may be also symptoms and signs of upper airway obstruction and dyspnea. The diagnosis of a peritonsillar abscess is usually suspected clinically and can be established with needle aspiration of pus from the peritonsillar space. This would establish the diagnosis and differentiate between a peritonsillar abscess or just a cellulitis. It also provides material for bacteriology, and that can be helpful in recurrent or non-responsive quinsies to have the right antibiotic for the infection, and also the needle aspiration can be curative in more than 80% of the cases. Imaging for a peritonsillar abscess is not required routinely. Transoral ultrasound is a non-invasive method and helps in differentiating between cellulitis and an abscess formation with a fairly good sensitivity and specificity. It also can guide the application of a needle for aspiration or a knife for drainage. It's usually performed intraorally through an endocavitary transducer, but sometimes due to trismus or patient discomfort, submandibular scanning would be required. The findings would show a hypoechoic site of the abscess, sometimes surrounded by a hyperechoic rim of tissues in here. The hypoecho area can be heterogeneous, and you could estimate the amount of fluid and pus from the scan. The other advantage it would show, if you're using a color flow Doppler, you could identify the big blood vessels surrounding the abscess, like the vessels in the parapharyngeal space, the internal carotid artery. If there is any suspicion of spread of the quinsy beyond the peritonsillar space, or in cases of recurrent quinsies not responding to management, a computed tomography scan can be useful. It would confirm the diagnosis of the abscess in almost 100% of the cases. It's very sensitive but less specific. It would show a low density area with an area of rim enhancement around it, and will also identify the big vessels around the quinsy, and would detect any spread of the separation into the parapharyngeal space or the retropharyngeus space or beyond into the mediastinum. MRI scans are less often used because they are more expensive and less available, and also more time consuming, but they allow a better soft tissue resolution. You could see clearly the tonsils and the peritonsillar space separation around it, and there is no radiation exposure, and it is therefore the imaging modality of choice in children. And if MR angiography is used, it can rule out or in suspected vascular anomalies. The area of round or crescentic homogeneous high density would be shown on the T2 weighted. On the T1 weighted post contrast with fat suppression, it would be hypoechoic, and the accuracy is extremely high, both in sensitivity and specificity, with an accuracy of about 96%. Infectious mononucleosis, got other names like glandular fever and Fevers disease, is a common, acute, and systemic viral infection. It's in fact the most clinically relevant form of viral pharyngitis, and is caused by Epstein-Barr virus in more than 90% of the cases, with a small contribution from other agents, including, for example, cytomegalovirus. The Epstein-Barr virus is one of 6 human herpes viruses, the human herpes virus number 4, and it can be isolated from the blood of the patient, lymph nodes, and their saliva. And this is, of course, relevant because this is how the disease is transmitted. It has a classical triad of symptoms: sore throat and fever, accompanied by a significant lymphadenopathy in the neck and elsewhere, hence the name, the glandular fever, and it has a fairly long incubation period between 4 and 8 weeks. Infectious mononucleosis is primarily a disease of the young adults between the age of 15 and 25 or so, but it can present in early childhood as well as in older age groups. The incidence is quite high, estimated at 500 new cases in every 100,000 persons per year, and is transmitted by saliva, and that's how it got its other name. It's described as the kissing disease. Most of the adult population had already had a glandular fever, either in the clinical or a subclinical form, because most of the adult population have already antibody titers in their serum. The course of the disease is usually for 7 to 10 days for the sore throat and the pharyngitis, but lymphadenopathy can remain a bit longer, up to 2 weeks. And what's relevant is that malaise and fatigue could persist for a month or even more sometimes. It usually starts with a prodroma of 4 or 5 days with malaise and fatigue and headaches, followed by the triad of the disease, the most common of which is tender cervical lymph nodes, followed by fever and a sore throat from the pharyngitis. The pharyngeal inflammation can cause a range of different manifestations, ranging from just acute follicular tonsillitis to a gray membrane over the tonsils and other parts of the pharynx, including the nasopharyngeal lymphoid tissue and the base of the tongue lymphoid tissue as well. The other features would include petechiae on the soft palate, and in about 50% of the cases there may be some abdominal discomfort and tenderness due to splenomegaly and hepatomegaly. Infectious mononucleosis must be distinguished from the streptococcal tonsillitis. The two conditions may have a fairly similar clinical features with some subtle differences sometimes. Among these differences is that in the infectious mononucleosis, there is usually an exudative form of tonsillitis with grayish membrane over the tonsil. And that grayish membrane may actually extend into other lymphoid tissue in the base of the tongue and can be seen on nasoendoscopy over the nasopharyngeal lymphoid pad, which will be seen as hypertrophied and covered with the whitish membrane. The other feature is the lymphadenopathy in the neck is usually in the anterior part of the neck, the jugular-digastric in the case of streptococcal pharyngitis and tonsillitis. In the infectious mononucleosis, it could affect the anterior and the posterior triangles of the neck as well, and can sometimes also extend to other parts of the body. The specific features of infectious mononucleosis would include things like splenomegaly and hepatomegaly, and also a higher tendency to have an airway compromise and difficulty in breathing due to the florid hypertrophy of the lymphoid tissue. But sometimes differentiation between the two conditions would rest on blood tests. Among the other features of infectious mononucleosis is splenomegaly, that can be detected in up to 50% of the patients. And this can be sinister because a splenic rupture can follow blunt trauma to the abdomen or sometimes splenic infarcts. There may be also hepatomegaly and jaundice that can be seen between 5 and 10% of the cases. But what is more relevant is that liver function tests are usually abnormal, particularly transaminases enzymes are always elevated. And if the patient have been prescribed any ampicillin or ampicillin-based antibiotics, almost invariably they're going to develop a skin rash of maculopapular reddish rash. If a patient develops bilateral peritonsillar abscess, bilateral Quinsy, this is almost diagnostic of infectious mononucleosis because it's very rare to happen with streptococcal or other mixed flora. Peritonsillar abscesses. The hypertrophy of the lymphoid tissue in the Waldeye's ring is also quite significant, and as you can see here, there is such a florid enlargement of the tonsils and the postnasal space lymphoid tissue. Sometimes this can cause airway compromise and have to be attended for either medically or surgically. The other less common and rare clinical signs of infectious mononucleosis includes periorbital edema in the eyelids. This is called the Hoagland sign. You could see the bilateral edema in the upper eyelids in this case. They may also present with cranial nerves involvement, either mono or polyneuropathies. Facial nerve weakness is the most common, but other cranial nerves can be affected, including the hypoglossal, the oculomotor, and the vagus, either in isolation or in combination like a polyneuropathy. In a clinical setting, we'll be looking for a screening test that is available, not expensive, and would give results in the early phases of the disease rather than waiting for immunoglobulins, for example. The lymphocyte count and lymphocyte to white blood count ratio can provide such a test with certain limitations. As you can see, the difference between a classic glandular fever blood test and the tonsillitis from streptococcal infection and other types of infection, you would see an elevated white blood counts in both, more marked with the streptococcal infection. At most of the streptococcal infection, elevation is due to neutrophil count rather than lymphocytes. Lymphocytes would be elevated more in the glandular fever group. and the ratio between the lymphocytes count and the white count would be more than 50% in the glandular fever group and would be about 10% in the tonsillitis group. So it's a quick screening test to differentiate between the glandular fever and other forms of acute tonsillitis. A ratio more of lymphocytes to white cell count between 35 and 50% could indicate glandular fever. A large retrospective analysis of more than 1,000 patients of confirmed infectious mononucleosis by immunoglobulins showed a sensitivity of about 70% and a bit higher specificity. So this is a useful test, but should be only used to differentiate the infectious mononucleosis, provided the other Hoagland criteria are there and present. And now to the serological tests. The heterophil antibody test has remained the basis for one of the most common diagnostic tests for infectious mononucleosis for almost 90 years or so. It was first introduced by Paul and Bunnell as early as 90 years ago, who discovered that the serum of the infected patients, when mixed with the sheep erythrocytes, could cause the erythrocytes to agglutinate. The monospot test, which is based on the same phenomena, uses bovine erythrocytes extracted antigen rather than sheep erythrocytes to detect the heterophil antibody. And the most common serological test today is based on this. It's a good screening test because the sensitivity and the specificity is far from being perfect. We would see now examples of false positive and false negative for it, but it remains a useful screening test. A monospot test would miss 1 out of every 7 cases of true infectious mononucleosis. The reasons for these false negative heterophil antibody tests is this: the level of the heterophil antibody starts to rise in the acute phase but may not reach a threshold for few weeks. So in the first 2 weeks, only about 60% of the patients would have enough immunoglobulin, heterophil immunoglobulin, to give a positive test. It will eventually rise up to a peak, and 90% of the young adults will become positive, but 10% would not. These are probably cases of infectious mononucleosis caused by other agents, not the Epstein-Barr virus, like the cytomegalovirus, for example. The other thing is that it would rarely be positive for children below the age of 5 years. So all these are causes for a false negative monospot test. It can also give false positive results, even in healthy controls, in cases with mumps, systemic lupus, erythematosus, Mediterranean fever, diabetes, and sarcoidosis. And the gold standard test would be based on immunoglobulin M. This would rise also early enough in the infection and would subside very quickly after the acute phase of the infection. It is immunoglobulin M is antibodies towards a viral capsid antigen found during the acute primary infection by Epstein-Barr virus. The other tests that are less used includes PCR real-time and measurements of the Epstein-Barr virus loads, and these can help in the early diagnosis of infectious mononucleosis in case other tests, the serological tests, were inconclusive. Scarlet fever is an exotoxin-mediated systemic disease caused by Streptococci group A beta hemolytic strep. These secretes an exotoxin that is now termed streptococcal pyrogenic exotoxin, SPE. The risk of scarlet fever posing is now far less severe than what it was 2 centuries ago. The death rate then was almost 1 in 2. But since the introduction of penicillin, this has changed dramatically, and scarlet fever is now much less common and fatality is extremely rare. The symptoms are very nonspecific in the early stages, and it's difficult to diagnose scarlet fever in the first 24 or 48 hours. There will be an abrupt rise of temperature, often above 39 degrees, together with malaise, shivering, tachycardia, and headaches. There will also be sore throat and pain on swallowing, and a typical bad breath with some shortness of the breath as well, combined in young children with abdominal pain and vomiting. So that's very non-specific in the very early stages of the disease, the first 24 to 48 hours. But what is important is that cough, rhinorrhea, hoarseness of voice, conjunctivitis, or irritation or diarrhea are notably absent. These features would suggest more a viral cause for the sore throat rather than a streptococcal pharyngitis causing the scarlet fever. But within 24 to 48 hours, there will be some oral signs that will give a clue about the nature of the disease. There will be an exudative type of pharyngitis or tonsillitis with a grayish membrane over the tonsils and sometimes the posterior part of the pharynx as well. There will be soft palate petechiae that may extend over the anterior pillar of the tonsils, and there will be the white strawberry tongue caused by the coating of the tongue with whitish debris through which some of the tongue papillae could be seen. These are early signs, these three signs, early oral examination signs. Few days later, the tongue papillae would regrow and would show and become obvious on the tongue surface, giving the typical appearance of the red strawberry tongue. And these are the oral features of the scarlet fever. Examination of the face would show obvious flushing of the cheeks that has the ugly name of slapped cheek. But this would be also a circumoral pallor. There will be a pallor around the mouth in contrast to the congestion of the cheeks. And the neck examination would show enlarged and tender anterior cervical lymph nodes, particularly the jugular-digastric nodes. 24 hours later, the skin rash would be noticed. This would be seen in almost all cases, about 90% of cases of scarlet fever, and in 70% of the cases they would start 24 hours after the sore throat and the oral and the facial signs. The rash would start in the groin or the axilla and will spread over the trunk bilaterally. It is formed of red, minute papules, tiny papules that gives the skin surface fine irregularities. This irregularity gives the skin surface the roughness that give it the name of sandpaper erythematous rash. And pressure on the rash would cause fading of the erythema, except in areas like the wrist or the elbow, the flexor parts of the elbow and the wrist, where straight lines with a very distinct color would show on the pressing the rash. This has been called the Bastia lines. In about 6 to 9 days, the rash would start to desquamate. It starts in the face, behind the auricles, and extends in the axilla and the groin, but also in the palms and the fingers of the hand. You would see the desquamation of the skin, and this desquamation would dry up and peels off ultimately. The diagnosis is difficult to start with in the very early stages, where the signs and symptoms are non-specific, with high fever, tachycardia, and tonsil and pharyngeal yellowish membrane with anterior cervical lymph nodes enlargement. There will be some specific features like enlarged papillae on the tongue, giving the strawberry tongue appearance, and the petechiae of the soft palate. But it is the spreading of the bilateral trunk rash that results in a confident diagnosis. The other important feature is that about half of the cases would report another family member is also unwell because the disease is very contagious. The gold standard for confirmation of the diagnosis of strep pyogenes would be either a positive throat swab culture that would need to be collected properly from the throat and by rubbing into the tonsils and the tonsil pillars only, and avoid touching the lips and the tongue. But the problem with throat swabs and cultures from throat swabs is that it would take few days for the results to show up. A more convenient and faster way of obtaining quite similar results would be the rapid antigen test, which will give the results in few minutes. It's highly specific with 95% specificity. The real advantage is immediate diagnosis, and this would obviate the need for the throat swab and culture and give the clinician the chance of immediate prescription of antibiotics. Serological assays for antibodies of strep pyogenes are not very useful. Measuring streptolysin or titr, for example, is not useful because it would take few weeks, 1 to 2 weeks, to start to rise in the serum after the onset of the infection and would reach the maximum level in 3 or 4 weeks. So it's not very useful in the diagnosis in the acute phase. The non-group A beta hemolytic strep include mainly the group C and group G streptococci. They are basically responsible for food-borne and waterborne outbreaks of pharyngitis. Some of these organisms are normal commensals in the throat, so it may be difficult to differentiate between a carrier state or a recent infection if the throat culture show C or a group C or group G streptococci. But they can produce an acute pharyngitis with clinical symptoms quite similar to the group A, but generally a bit milder, less severe. And in addition, the group C and group G can also have non-suppurative complications of the streptococcal infection. They may be associated with acute glomerulonephritis, but it has never been shown that group C or group G could cause an acute rheumatic fever. And they can be treated in the same way like group A with penicillin or with clindamycin. Fusobacterium necrophorum, which causes the Lemierre syndrome, is an anaerobic gram-negative bacterium. It causes this potentially life-threatening condition that starts with a sore throat, an oropharyngeal infection, abscess formation in the oral cavity or the pharynx, and a thrombosis of the internal jugular vein. And usually it affects adolescents and young adults. It can be detected as a commensal in up to 7% of healthy controls, but its prevalence would increase to 18% in cases of a sore throat and raises up more, up to 21% in cases of high grades of Centor score like grade 3 or grade 4. A throat swab culture can also be useful in the confirmation of a Cyanobacterium diphtheria infection. It's quite rare nowadays. It gives the patient a white grayish pseudomembrane, not limited to the tonsils, but involve the surrounding mucosa of the soft palate and the pharynx, and the mucosa would bleed easily on touch. It can be serious and can threaten acute upper airway obstruction and can produce exotoxin as well. Some of them can affect the heart. The diagnosis can be confirmed microbiologically on a throat culture, but it needs to be sent on a special request form for a special culture media. But they can also be detected serologically by PCR tests to detect the toxins and the antibodies to the toxin in the serum. And of course, since 2020, the COVID-19 needs to be considered in the differential diagnosis of all new onset acute sore throats or respiratory infections. They have some particular symptoms or signs, including the cough, the elevated temperature, the difficulty in the breathing, and the anosmia, as well as it affects more patients who have been in close contact with other individuals who tested positive. This should be a part of the differential diagnosis, and there are special tests to confirm the COVID-19 diagnosis. Acute rheumatic fever is now uncommon in most developed countries. But rheumatic heart diseases that follows the acute rheumatic fever is still responsible for an estimated 300,000 premature or preventable deaths per year worldwide in other parts of the world. The antistreptolysin or titr that is frequently used to detect such a condition is not very useful in the workup of acute sore throat or acute tonsillitis, because it may reflect past and not present immunological events. And even if the throat culture shows that group A beta hemolytic strep with an elevated level of ASLO, it doesn't really indicate whether the presence of group A beta hemolytic is due to a recent infection or just a streptococcus carrier. And there is no evidence or any cut-off point that at a specific level in the rise of the ASLO titr, tonsillectomy should be considered or not. Streptolysin S and streptolysin O are certain virulent factors produced by the streptococci, the group A beta hemolytic streptococci, and the body would form antibodies against these virulent factors, and these antibodies, for example, the antistreptolysin O titr, can be measured in the blood and can be estimated as an expression of an immune response to the group A beta hemolytic strep. But the level would be very variable. Only 40% of proven cases of group A beta hemolytic strep tonsillitis would have an elevated level of antistreptolysin O titr. The other 60% would not. Also, if the level is elevated, it may persist in asymptomatic patients. Patients who have not had the infections may have an elevated and persistently elevated ASLO level. Because of this high variability, it is difficult to be used as a diagnostic parameter in relation to tonsillitis and pharyngitis. Even severe cases of group A beta hemolytic strep infection in the throat may not necessarily followed by release of high levels of ASLO. ASLO level, if it is progressively rising repeatedly in repeated tests, may be of interest to cardiologists who are suspecting clinically a case of acute rheumatic fever, but it is not of much value in the management of acute or recurrent tonsillitis or pharyngitis. The high variability of the ASLO level would mean that if it is increased, you could not just assume that this indicates that there is an antibody protection against streptococcal infection that is mounting a good immune response. This is not reflected in just a high level of ASLO, and you could not tell from a high level whether there is an increased risk of acute streptococcal disease or not, and you could not tell whether there is an increased risk of a severe form, a purulent form, for example, of streptococcal infection or not, and you could not make a prediction regarding the streptococcal carrier state or if the patient is more contagious or not. That's why it is not very useful in the context of management of acute tonsillitis or acute pharyngitis. When investigations are needed, one of the simplest investigations can be done is a full blood count. And in case of group A beta hemolytic strep, you would expect that these patients would have a higher total leukocytic count, mostly granulocytes, and they would also have a higher value of C-reactive protein. But the blood test in these cases has a low sensitivity and a lower specificity as well. ESR is not particularly useful, so it can be omitted because there is no much difference between bacterial and viral infections in the ESR rates, but C-reactive protein is important. C-reactive protein is just a non-specific marker released in the blood in response to various infections or inflammatory processes. Measuring it in acute sore throat can help in stratifying the risk of having a group A beta hemolytic strep and whether antibiotics are needed or not. We should generally expect a higher CRP in the case of bacterial infection causing the sore throat, but the cutoff point differs from a country to another. A German study, for example, suggested that the cutoff point is 35 milligrams per liter. Above that, it is probably a group A beta hemolytic strep infection, and below that, it is improbable. A Norwegian study suggested that the cutoff point is a bit lower at 25 milligrams per liter. The NICE guidelines, the National Institute of Clinical Excellence in the UK in 2016, suggested that the CRP values should be a bit higher. They say that if the CRP is less than 20, then the probability of a bacterial infection is very low. If it is between 20 and 100, then there is a high probability, but if the clinician may consider giving a delayed prescription to be used only if the condition is getting worse. It's only if the CRP level is above 100 milligrams liter, in contrast to the German and the Norwegian studies, that immediate antibiotics should be started. Throat swab cultures are particularly important with some infections caused by anaerobic bacteria, including peritonsillar abscess, basically the type 2 abscess. Type 1 peritonsillar abscess are basically formed due to heavy group A beta hemolytic strep. Type 2 have a heavy polymicrobial growth, some of them anaerobes, including Fusobacterium necrophorum, and also some streptococci, which are aerobes. Type 2 is the more severe form of the peritonsillar abscess. The other anaerobes that can cause serious infections in the throat include, for example, the Lemierre syndrome caused by Fusobacterium necrophorum, and this can be a life-threatening condition because of the thrombosis of the internal jugular vein. In addition to Vincent angina, which causes a unilateral gray tonsil ulcerative or exudative membrane, which can be painless and associated with significant halitosis and cervical or oral or pharyngeal abscess formation. It's usually a mixed type of infection formed from spirochetes and fusiform bacteria like Treponema vincenti and others, or Fusobacterium nucleatum and others. Rapid antigen detection tests were developed to detect and confirm or exclude the diagnosis of group A beta hemolytic strep within minutes, basically because a throat culture requires an incubation period for between 24 and 48 hours. So this will provide a much quicker way of confirming or excluding the condition so that antibiotics may be started quickly, or a decision not to treat with antibiotics can be reached within minutes. It has a lower sensitivity compared to the throat culture, and it does not detect other forms of streptococcal infections like group C or group G. It's basically designed to detect group A only, but it's still very useful because by excluding the infection by group A, the use of antibiotics had dropped significantly in the patients who tested negative. But because it has a lower sensitivity, it should not be the only way of confirming the diagnosis of group A beta hemolytic strep in areas in which the acute rheumatic fever is more prevalent than in Western societies, for example. By this, we come to the end of this presentation on evidence-based medicine in the assessment of acute sore throat. Assalamu alaikum.